साइड में बैठो तो बार बार हिलेगा ना।
चालू हो कहाँ बैठे? कहाँ
So, ladies and gentlemen, we warmly welcome you back as we reconvene for the post-lunch technical session. Before we proceed with the next technical session, we would like to take a moment to express our sincere gratitude to our esteemed sponsor. Their generous support and continued encouragement have been instrumental in the successful organization of this conference. We thank them for their invaluable contribution. We now commence plenary session 2, centered on the theme Innovation, Evidence and Transformation in Contemporary Science, Healthcare and Research Ecosystem. This session will be chaired by our distinguished academicians, Dr. Supriya Awasthi, Dean School, Allied Health Sciences, Noida International University, and Dr. Hema Chaudhary, Dean School of Pharmacy, K.R. Mangalam University, Gurugram. Ma'am, kindly take your seats on the dais.
इसका अलग लिंक होगा ना? इसका अलग लिंक होगा ना?
वो साहिल जी बताएंगे। साहिल से पता
कौन सा?
साहिल जो यहाँ बैठे हैं ना चश्मे वाले।
अच्छा, क्योंकि बीच में आपने बंद किया था ना, वो पुराना वाला ही चल रहा था उस लिंक पे।
उसे पूछ लीजिए।
आई नहीं अभी वो।
या वो एल सी भी
शेयर कर
एल सी
या आपने लगा वो लगा के गए?
नहीं लगा। मेरे को आइडिया नहीं भाई, वो बताएंगे लिंक साहिल जी।
कहाँ उनका नंबर बताओ। नंबर बोलना।
So our first presentation shifts our focus towards integrative physiotherapy and functional restoration, highlighting innovative approaches in clinical practice. We are honored to have Professor Dr. Pallav Bhatnagar, who is distinguished senior consultant physiotherapist, academic leader and educator with over 2 decades of experience in physiotherapy practice, teaching and institutional leadership. He holds a Bachelor of Physiotherapy and a Master of Physiotherapy in cardiorespiratory therapy from Rajiv Gandhi University of Health Sciences, Bangalore, and is a member of Indian Association of Physiotherapists, currently serving as the Principal, College of Physiotherapy at Gitanjali University, Udaipur. Dr. Bhatnagar is widely respected for his excellence in academics, mentorship, and clinical expertise. His professional contributions have been recognized with numerous prestigious honors, including the Lifetime Achievement Award in Physiotherapy and Rehabilitation, National Bidden Award and Academic Excellence Award, and Best Physiotherapy Teachers Award, among others. An active keynote speaker and a resource person, he has delivered expert talks and a scientific presentation at national and international conferences. Deeply committed to continuous professional development, Dr. Bhatnagar has undergone extensive advanced training in musculoskeletal, neuro-rehab, cardiorespiratory therapy, ergonomics, dry needling, and movement sciences. dedication, evidence-based practice, and holistic patient care has made him a prominent and inspiring figure in the field of physiotherapy. He'll be sharing with us breath work training and emerging roadmap for restoring facial tensibility. We welcome you, sir.
Good afternoon. Post-lunch session, right? I would like to express my sincere gratitude to the organizers who have given me this opportunity to share the idea of breathwork training, which is definitely an emerging roadmap for restoring fascial tensibility. And coming to the point, the carry-home message, what I am trying to prove with my talk, I won't take much time. But carry-home message is, there is a situation of sensory motor amnesia, there is a term we call it SMA, when the thoracic diaphragm has no idea about the central governance in human body. The entire whistle rhythm is disturbed, and that is the point of discussion here. And my sincere approach, right past 20 years, in any platform I always request all the young budding physios that do incorporate the respiratory mechanics along with your physiotherapeutic approaches. So, point comes, what is breathwork training? Breathwork training is not just about wellness, it is also about the entire respiratokinetics, which is the biomechanics, we know it. Rib kinetic dysfunctions are very common in human body. We don't address this then and there at the time of onset, but once they manifest the symptom in human body, then only we try to address them. And the entire thing is about the neuromuscular control of the breathing mechanics. So we are talking of software, not the hardware here. So it is the physiology which defines anatomy, it is not the other way around. And the last but not the least is the entire nervous system regulation, which is more to do with the peripheral dominance than the central dominance. Our life is lived between the first inhale and the last exhale, no doubt about it. We all are clear, we are on this planet, we have some limitations. There is a concept in breathwork disorders, breathing pattern disorders, we call it anecdotal story of moving heads of Hydra. Now, I don't want to discuss the entire story here, but to the nutshell is, when we just address the symptoms, we are just chopped. So if we chop one immortal head, 10 new heads will appear and we won't be able to address them. So it's like an iceberg phenomena where the breathing pattern disorders can be categorized into primary and secondary. Primary pulmonary pathology is well evident in physiotherapy practices, but the hidden and occult secondary pulmonary causes need to be emphasized. Coming to motor impairment categories, breathwork training incorporates neuromuscular system, musculoskeletal system, integumentary system, cardiovascular and pulmonary system, of course, and the new insight is the internal organs, and especially it is the gastrointestinal system. Today I will be emphasizing on gastrointestinal system in my talk. The function of thoracic diaphragm is respiratory, postural stability, point to be noted, spinal decompression, fluid dynamics, visceral health and emotional regulation. Arguably, no other muscle in the entire human body is so centrally placed like the thoracic diaphragm. And the patient is never a symptom localized, but a symptom that adapts to the corporeal dysfunction. And one interesting fact about the respiratory diaphragm is, this is the only muscle in human body which switched its origin and insertion in the middle of its function. So diaphragm is very intelligent and it knows how to adapt to the gravitational pressures and exercise pressures. Late in the historical era, Thomas Hanna has coined this term, sensory motor amnesia. Now what is sensory motor amnesia and how it is related to my talk? Let me integrate that. When the brain responds to the tightened musculatures of abdomen in response to fear and apprehension, it becomes a habituated restriction for the excursion of thoracic diaphragm. So once the excursion of thoracic diaphragm is reduced, it causes shallow culture of breathing. The Indian societies are today the shallow breather cultures, and that will compromise the entire cardiovascular system, leads to alternative breathing adaptation, which is called as apical breathing, and this is the onset of sensory motor amnesia, that we don't know that we don't know. Diaphragm is not working, diaphragm is clueless, and in the alteration of sensory inputs to the central nervous system, there can be three problems as a breathwork trainer when I face my patients. Number one, either there can be altered inputs to the CNS, there can be absent inputs to the CNS, or there can be a total clinical malingering which is being presented at the end of a visit. Increasing number of people, those who are experiencing chronic muscular pain, repetitive movement disorders, in the science we call it either repetitive strain injury or overuse injury, they all are nothing but they are stuck patterns of the sensory musculatures which is subjected to amnesia, and the muscle won't relax, and the muscle which is already contracted will neither contract more nor relax more. So the brain and the somatic nervous system controls the muscle. So we have two approaches available now. We call it psychosomatic approach in physiotherapy, and the reverse way is somatopsychic approach. Psychosomatic is when we are involving all the counseling and some verbal command methods in which we are just trying to mold the flesh part of human body. Flesh is nothing, it is the muscle. Or directly we are dealing with the flesh end and we are trying to mold the perceptual end. So these are the two different worlds in breathwork training. Now the problem statement. As a physio, why breathwork trainers have to struggle a lot with the patients? Because releasing muscle pain is an education process. We can't expect the patient to respond immediately. One misnomer term in our world is diaphragmatic breathing, which is not equivalent to abdominal breathing. Abdomen is the most misnomer term in that. So here I am not talking of the diaphragmatic breathing, I am talking of the control of the lateral costal expansions, which is the actual need of the heart to rebuild for our patients. So the entire idea is, when we are suffering with sensory motor amnesia, the CNS helps us to learn all new activities, like we learn how to walk, our postures, we know how to throw the ball, we can learn playing guitar if we don't know. So we call it motor learning and motor control. Similarly, brain does not distinguish between the good input and a bad input. You always say if there is a bad sensory input, there will be a bad motor output. So it is all about input. So brain has no idea how to distinguish between the good and the bad. So it's a matter of exposure. So what we are doing today in terms of neural control mechanism, we are the victim of autopilot mode, or we call it cruise control mode. And that makes us difficult to unlearn the activity and relearn the activity from point of view of respiratory mechanics. Now there are certain key markers as a breathwork training. We see zone of apposition, that is ZOA. We try to reconstruct the entire ribcage kinetics. We call it 360 reconstructions of ribcage, and we also try to restore the diaphragm pelvic synergy mechanisms. And the assess for all the young physios is, if we incorporate two assessments, the first assessment is MAM, manual assessment of respiratory motion. That is fantastic. It requires manual skill, clinical interpretation. It does not require any high-end technology. Palpation of rib, which is moving in some particular directions, and we need to identify the screening tools which are required to screen whether it is a primary problem or a secondary problem. Now the diaphragm as a tensional hub, tensigrity. Human body is a system of strain distributing machine. We can call ourselves as a strain distributing machine rather than a compressile loading system. Our axial skeleton was never designed for axial compression, and because of the compression, all secondary curvatures are under problem today. Primary curvatures are not being considered to be biomechanical fault at the primary level. So the diaphragm connects to thoracolumbar fascia, psoas fascia, pericardium, pleura, and the pelvic floor fascia. For the fascial world, what I am talking indirectly here is the deep front chain, which was given by Tom Mims. And every breath modulates intra-abdominal pressure. It alters the tension across these myofascial chains, which I have not included also, and the influences to the load transfer of the spine, pelvis and limb and vice versa. So our locomotion is principally dependent upon the initiation of intra-abdominal pressure. We call it core support system, right? So it's a dual function of the respiratory diaphragm. More than controlling respiration, diaphragm has an affair to control the posture that we need to understand. Think of a breathing as a rhythmic tuning to the tensibility system. So these are the strings of a guitar which we need to tune, rather than we can strengthen those muscles further, which are not being controlled at the central nervous system level. Now, during inhalation, we know that diaphragm has to descend down. This descent initiates especially the lateral and posterior expansion, and the fascial tensibility stores elastic energy. So we call it potential energy being stored in the elastic recoils. And the body biases is the expansion, extension and receptivity. I'll explain you, just give me 1 minute. Let me complete with exhalation. During exhalation, diaphragm ascends and the rib cage recoils. So rib cage recoils when rib cage descends down during the process of inhalation. So inhalation is an active process, as we all know, and exhalation is a passive recoiling process, but it requires fascial tension distribution. So if there is any pathogenesis or pathology which is interfering with this redistribution of fascial tension lines across the rib cage, it will also hamper the excursion of diaphragm. And if the excursion of diaphragm is altered, there will be no healthy movement, and we cannot imagine any locomotive function which is happening in a biomechanics entity. Everything will be cautioned under pathomechanics. Now, lymphatic system and tensibility has a huge link. As we know, breathing drives lymphatic flow, because lymphatic circulation has no central pump of its own. It has always to be dependent upon the pressure gradients. And the lymphatic system itself is a low pressure gradient system. So flow that depends on external forces, that is gravitational forces and the personal factor. And the breathing is one of the primary pump which is involved in the lymphatic return. As we know, diaphragm is lymphatic engine. During inhalation, diaphragm descends and the intra-abdominal pressure rises, intrathoracic pressure reduces, and the lymph is drawn upward to the thoracic duct. So this is the phase where the entire lymphatic returns takes place. And during exhalation, diaphragm ascends, pressure normalizes, lymph wells prevent backflow. So the mechanism of exhalation has to do lot with the stasis prevention system in human body. So in respiratory breath hold training, we say it is important to train the CO2 tolerance rather than O2. O2 is not the need. The primary aim of a respiratory kinetics is to restore the CO2 tolerance, and the pressure gradient is essential for lymphatic returns. Now, as we know, the lymphatic structures that affect the breath is 75% of the body lymph is contained during the thoracic duct excursion, and that passes through the diaphragm, and diaphragm is sensitive for excursion. So restricted breathing is equivalent to restricted lymph flow. Why I am talking of lymph flow? Fluid dynamics is important for the restoration of central nervous system regulation. So lymph reservoir in the upper abdomen is the system highly, and it responds to diaphragmatic movement and abdominal pressure changes. Shallow chest breathing, poor abdominal lymph propulsion. Now think of a patient who has been operated, either abdomen surgery has been done or a thoracic surgery has been done, or are there any scars, restrictions over the chest wall. So all these conventional post-operative cases will be badly affected, and they will be facing this not only for a couple of months, maybe it will be remaining for the rest of the life. Because once the sensory motor amnesia component is not addressed, it will be in autopilot mode. That will not be regained again. So lymph vessels which runs with fascial planes are very important for our understanding. Breathing changes these fascial tensions, and it improves the interstitial fluid movement, reduces stagnation via gentle oscillation. And slow breathing is better lymph transport than forceful breathing. The idea of breathing is witness consciousness. If anybody asks me in my practice, the breathing we are doing right from the birth, what is different as a therapeutic intervention? So in physiotherapy, we say when we make our patient aware mindfully what amount of technique you use to incorporate, if you want to rigging your controls, manual controls back. So we call it a rebirthing technique. At the time of birth, if you see a neonate now, neonate will be breathing from the abdomen. So once in adult life we are moving ahead, biological numbers are increasing, we are tend to losing the art of breathing from the abdomen, rather we are more fixing to the apical part. So higher costal expansion breathing is like living a life on an inverter mode, not on the electricity grid what God has given us for the longevity. And tensigrity is nothing, that's the body maintain its shape and transfers through the continuous tension and discontinuous compression. So it reminds me of John Gasmagen, the father of electromyography. He used to quote always, it is the muscles alive, bones are dead. I am repeating. Bones have no value of their own in locomotion. If bones are alive, then we can see the biology lab, the skeletons must be moving around us. So the muscles alive, bones are dead. If the muscles give a good physioelectric signal to the bones will do their job as a hormone mediator. Simple. So the diaphragm just doesn't work for the respiratory. It is a fantastic fascial tension regulator. So diaphragm is the thermostatic mechanism also. The temperature is being maintained because of the diaphragm, and it is a fascial tension regulator. So the breath, posture and the movement are intertwined. We cannot separate them. Breath is trained with movement. We call it vinyasa in traditional Indian culture. Vinyasa is one breath, one movement. In physiotherapy, RSI, which is my area of interest, somato-respiratory integration, we call it, if we include 1 degree plane of freedom with one breath, that will be registered centrally more pronounced than the peripheral fibers. So we inhale to facilitate thoracic extension and breathing timing for lifting and functional tasks. So all the biomechanical activity can be taught with the mindful control of the diaphragm. Now, a simple idea how we incorporate that in physiotherapy clinicals are, when we look up, try to inhale by rolling your eye upward. What you will notice is, we can all do together. The depth and the length of inspiration will increase. That's the God's magic. And when we look down, the exhalation improves. So that's a simple thing. And it's not just about breathing. If we want to improve thoracic extension, we have to look up. If we want to improve the thoracic flexion, we need to look down. So in that way, we can improve the range of motion. It's been proved. So there are chronic extension biases and chronic flexion biases. These are the assessment part where a breathwork training can pick the roadmap from where to initiate in rehabilitation. We can treat any patient from any background. It can be cardio, neuro, ortho, sports injury, or in wellness and fitness also. So in the fascial world, the fascia conducts information 25 times faster than the nervous system. Slow control breathing, we call it slow, low, deep. That's the formula. Breathing has to be always slow, low and deep breathing. It restores viscoelastic property of fascia. So what is viscoelasticity? Ideally we encounter it in our clinicals. Early morning stiffness is a part of viscoelastic mechanism. The reduced load, overload or redistribution tension systems are also part of it. That's why breathing can change ROM without stretching. It's a good tool. Pain without touching the painful areas. So it can mediate and modulate pain as well. And it may provide stability without enforcing strength. So core stability comes with the concept of RMT, that is called as respiratory muscle training. And we are targeting inner core, that is transverse abdominis. One information about TA is, it is arguably the most closest muscle, the first line contact of muscle to the viscera. Let's come to some happening portion of it. My job, my work with the patient is restorative techniques. Let us come to the application part in physiotherapy. Now we know there is a sensory motor coupling mechanisms. So all the senses, all the sensory inputs will go to the central nervous system. There they will be processed and then we will get a motor output. So bad sensory input, bad motor output. Good sensory input, good motor output. For the purpose of division of breathwork training, the entire thoracic rib cage is divided into 4 parts. So we have first 2 neck ribs, which are called as cervical ribs. Then we have 3 chest ribs, those are thoracic ribs. And then we have 4 abdominal ribs, which are linked with parasympathetic tone. And the last 3 pelvic ribs, which helps us for synergy mechanisms. So the entire idea of formulative sessions is, first priority is to balance the pelvis and the lower limb. So point to be noted is, lower limb goes with the pelvis. Second step is balance the rib cage with the upper limb. Again, point to be noted is, upper limb goes with the rib cage. And the last is to balance the spine. So spine comes the last. So any patient who is walking with any spinal pathology or a spinal complaint, we need to reconstruct the entire rib cage. Okay? So movement re-education, that's the only way to internal awareness of our body. Journey towards developing the skill of internal physical perception and experience. So I was talking of witness consciousness. So when I ask my patient to breathe in a certain manner, the patient has to mindfully execute it. Casually we cannot execute. Casually what we are executing is already embedded breathing pattern. So breathing retraining according to the Bradcliffe physiotherapy approach, which is one of the famous approach being adapted in the entire geography globe now, especially Australian continent. Again, the awareness of fully breathing pattern is required to the patient, relaxation of the jaw, upper chest, shoulders and all the accessory muscles, that is the second call. The third is abdomen, the low chest, nose, breathing patterns and re-education. Then comes the awareness of normal breathing, that is the rate and rhythms, both at rest and during speech and activity. So dyspnea of phonation, dyspnea of exhalation, these two are different terms. And SOBs are again primary pulmonary pathology symptoms, which are not to be addressed here. I am not confusing with SOB. Our training goes with DOP, dyspnea of phonation more rather than the exertional dyspnea. The reason for that is the vocal cords are the top 12 of the core cupboard. So there is a simple test, we call it sniff test. We can do it all. Simple test, sniff test. This sniff test is used for testing the diaphragm in clinical setups. So to test both diaphragm functions, that is the left hemidiaphragm and the right hemidiaphragm, we use this test. And it is an excellent tool which is having validity and reliability. And we can also ask the patient to go for high-low breathing maneuver. And that is another confirmatory test whether there is a sensory motor amnesia or not. Then there is a clinical outcome test, we call it Bradcliffe angle check. And the narrower the Bradcliffe angle, more is the pathology. And the wider the Bradcliffe angle is, more obtuse it is better. We have so many, I have a case study where I started with gastroesophageal reflux treatment. In that, the Bradcliffe angle, the moment I achieve wider Bradcliffe angle, the entire symptoms reversed. Now, a typical respiratory prescription looks like I is to P1 is to E is to P2. It is not FITT. It is not frequency, it is not intensity, it is not time, and it is not time. For a respiratory therapist, our world rules around these 4 parameters, which are I, inspiration, P1, post-inspiratory pause, which is Antargumbaka in ancient science. Then comes exhalation, and then comes P2, which is post-expiratory pause. It is not pre-inspiratory pause. Again, the terminology need to be understood. Now, these ventilatory pattern and training breathing strategies, what we can do as a thumb rule, the spine extension always incorporate inhalation with spinal extension. That is the first rule. It's a thumb rule. We incorporate spinal extension with inhalation. Simple. If you think of Surya Namaskara in the background, you will be able to say. Ancient India used to know it. Next is, whenever we want to incorporate spinal flexion, we have to go for expiration. Eye gaze roll upward, inspiration. Eye gaze roll downward, expiration. Eye gaze fixation is a problem statement for Indian society across the globe. People those who are working on screens for long, those who are fixed on mobile screens, students those who are studying a lot, they all have eye gaze fixation, right? More eye gaze fixation means there will be a hypoventilatory mechanisms which are being embedded into the diaphragm, and diaphragm will be again acquainted to those kind of atmospheres. So what is the rule? Even Google company endorsed to the new joining they take a consent and underwriting. They call it 20-20-20 rule. Simple rule. After every 20 minutes, take a 20-second break and look 20 feet distance. So by looking at 20 feet distance far, we are changing the eye gaze, nothing else. So there are different types of breathing patterns which we are using. That is cardiac coherence training, which is used for calming the patient and relax the anxiety. Slow paced breathing lowers blood pressure. COPD breathing, again, it reverses SOB. And Dr. Andrew Well breathing technique, which is the famous technique today. It is available on Instagram almost in each and every reel feed. It is used for insomnia and it is a wonderful and fantastic technique. US Navy has done a study on insomnia, and they have come up with the idea that when you are lying down, you have to practice this 4780 technique along with incorporation of the movement of the little toe of the foot. So if you are isolating it, again one breath, one movement, that becomes vinyasa connection, and immediately you will fall asleep. Now these are the group of muscles typically that is to be incorporated for tuning. So what we are tuning is neuromotor tone. Don't say we are releasing the muscle, we are stretching the muscle. Our idea is to normalize the tone. The muscle which is having more tone is also a problem statement, and the muscle which is having less tone is also a problem statement. So pectoralis major muscle, scalene muscle. The importance of scalene is the driver of dominoes effect for respiratory kinetics. Now having said this, the anterior scalene initiates the inhalation. That's the key. So the first rib is pulled by anterior scalene, and then second, third, fourth, fifth, that's a dominoes effect. Now the point is, first four ribs are sympathetic tone, they are sympathetic nervous system. Fifth is neutral, it is the line of control between the sympathetic and parasympathetic. So fifth rib is hypokinetic rib, always. In our assessment we can go and check. And the lower ribs are the parasympathetic ribs. So scalene muscles, sternocleidomastoid, all abdominal muscles, irrespective their attachment with the semilunar lines in the front and lateral raphe at the posterior, we need to reconstruct through transverse abdomen. And then comes quadratus lumborum muscle in isolation, because if the glutes are not firing, they are not making a synchrony idea with the pelvis, again there is a problem statement with secondary curvature will be obliterated in the lumbar. So spinal extensor muscles are the victims for that. And in ancient biomechanical studies of Lasagna and biomechanics, we have seen it with the name of flexion relaxation, FR phenomenon. So for prolonged setting, if we flex, the EMG electrical silence will be achieved in multifidus muscle. And the moment we try to set erect stance, there will be again a noise in EMG recording. So that's more important. And in my practice as a respiratory therapist, I have seen game changer muscle is hip external rotators. They are game changers. So thoracic cavity, abdominal cavity and the pelvic cavity, they must accommodate expansion of respiration. And this is called as eccentric isometric contraction control. So we need to train two muscles in caution in periphery for locomotion. That is, first is hamstring muscle. So eccentric activity of the hamstring and the eccentric activity of psoas major, sparing iliacus fibers. Simple techniques what I use for my clients under somato-respiratory integration, that is SRI, body scans which are very important, arch and flatten approach, arch and curl approach, back lifts, diagonal arch and curls approach, the flower technique. Mark this technique, it is one of the most important technique which incorporates the entire human systems. It is the rhythm orchestra. Diaphragm is the master band of rhythm orchestra. Side bends, propellers, wash rag technique. So 6th is flower, 9th is wash rag. We can underline these two techniques. These are holistic approach in human body. Hip hinge, capital X technique, which is used for structural integration, which is the later part of the rehabilitation process. And then inversion and eversion technique, which is again used for reconstruction of the foot. We will come to foot at the end of this. And the arches of the foot has direct link to these flower and wash rag techniques. Then comes the skiing, steeple test, twist technique, walking technique, seated twist technique, relax, release and proprioception 1. Now these are standard 18 techniques under this technique. Proprioception 1 starts with the intraoral MFR, myofascial release. So once we are going and reconstructing both pterygoids, lateral and medial pterygoids, then we can think of some proprioceptive inputs that can be organized at the peripheral governance, not at the central governance. And at the end, there are simple things. What I do, I just want to share with you is, there is a secret technique in ancient India, we call it pranayama. In pranayama, the concept of the people is to breathe in and breathe out. Take a deep breath, take a deep breath out. That is not physiotherapy. Any technician can do that. Now the point is, when we want to educate someone how to breathe, little is enough. The formula is little is enough. More commands we give, more claudication clusters will be there and patient will be confused. So there is a technique in which we can use physiotherapy for changing the energy circuits of the body. Now what are these energy circuits? Energy circuits are nothing. They move into 5 dominant component of the parts. In ancient yoga, they call it prana vayus. So there are total 5 prana vayus and 10 up prana vayus. I'll give you only one example. All the pathology of lower limb, where patient complains of pain to the lower limb, numbness, tingling, paresthesia, neural claudication, vascular claudication, anything it may be, anything which has to do with the lower limbs has a disorder of apana vayu. That's for sure. And how to restore that in breathing mechanics? It's by simple setting techniques, like in meditative postures. Now, what is the simple thing I want to emphasize here? You can just look at this diagram on the left hand side. Now, the position of the knee joint, if it is inferior to the hip joint while sitting, prana vayu will be definitely obstructed. It will never open. So, any sitting exercises, any sitting postures, what we are endorsing to the patient, rather than going only to the muscular skeletal biases, let's incorporate the central respiratory control mechanisms and incorporate the thoracic diaphragm. The moment we elevate the hip joint with reference to the knee joint, the circulatory disturbances omits. As simple as. So there are many rules of RSIs, respiratory somatic integration. This is just one what I am sharing with you. Second is, when we are working with the integration of upper rib cage with the upper limb, we should take care of exhalation techniques. Thoracic expansion exercise are again under research, and it is a big question mark today because more and more thoracic expansion biases we are giving without correcting the diaphragm mechanism, excursion, that will further reinforce the stasis. Now the point, what I'm trying to prove here is, technique is not wrong, exercise is not wrong, but the timing when we are introducing it to the patient, that need to be checked properly, right? This is a simple book lift technique. This technique goes back to the Japanese breathing technique in breathwork training. There is a technique which is called as innocenti breathing. I think you must have heard of it. How many have you heard of innocenti techniques? So the innocenti technique is nothing, it is the 10% effort which is used to breathe from the lateral costal part. And it goes for resonance frequency breathing. It means the respiratory rate will drop to 6 to 8 breaths per minute. And that is consonance state of the mind. That is consonance state of the mind. So what we do ideally, we educate the patient for innocenti, then we take them to the outcome tool to check high and low. We call it high chest, low chest maneuver. And then we will ask them to go for thoracic expansion opening with spinal elevation. So we may keep a thoracic roll or a towel roll in the entire spine, and that leads to the development of rotation of clavicles posture. So 1 to 2 degree of clavicular rotation is important if we want to achieve the dominus effect. Now think of the society which is having round shoulder posture, forward head neck posture, okay, or chicken head posture we call it. Some people, those are having visual disturbances, hearing disturbances, so they will be concentrating while watching televisions. If you are sitting in a crowded area, if you are not able to concentrate, you will try to pose, okay fine, what is happening? So the entire insult gets stored to the central respiratory mechanism. What all things we are doing? There are only 2 ways of approaching respiratory breathwork training. I see whether the patient is coming with the personal factor problems or environmental factor problems. So personal factor problems lies within the person, and the environmental problems lies outside the person. Now, how valid it is if I am prescribing the therapeutic intervention which is addressing the environmental factor, not the personal factor? This is my question, serious question, because if you are not incorporating the reversal of sensory motor amnesia, despite we are giving good efforts to the patient, we won't be able to balance the patient for a long-term success. Our results will be reversible. Simple weight techniques with this innocenti, we start with 5 kilograms, as low as 5 kilograms, as high as 50 kilograms. And one of the client I had gone to 80 kilograms also. And that was tremendous. Outcome measures were PFTs and VO2 max, and both have shown improvement. At the end, summarizing my talk, I won't take much time. The goddess of physiotherapy, Professor Ida Pauline Rolfe, her authentic literature work incorporates the concept of literal thorn, literal flesh. She used to say, if there is a thorn here, the same thorn is being reflected in the flesh. जैसा कांटा दिमाग में है, वैसा ही कांटा फ्लैश में है. So there are two approaches now. Either you can remove the thorn from the psychic, which is called a psychosomatic approach, or you can remove the thorn from the soma, which is called a somatopsychic approach. As simple as. So the physical trauma pain, the emotional trauma pain, and the pain received as escaping the body are the three pains to be addressed in human body. When a client comes and explains that, sir, I am having pain, so that patient is reporting the perceived pain, and pain has a memory. Exactly. Past 20 years I am suffering with low back pain. Means what? It's a memory. Then emotional trauma pain, that is always embedded and quite often missed by the reporting time or the interview sessions. And most important is the pain which is escaping the body. Most of the patients, most of the clients, they fail to report that. And as a therapist, because I am not dealing with sensory motor amnesia, even I skip it most of the times why pain is not changing. So the first challenge is the feats. हम कितना भी साइंस की बात कर रहे हैं, सेंसरी मोटर एमनीसिया, रेस्पिरेटरी काइनेटिक्स, सोमेटो रेस्पिरेटरी इंटीग्रेशन, देयर इज अ ब्रांच व्हिच इज कॉल्ड एज सोमेटिक एजुकेशन ब्रांच एज वेल, देयर इज अ माम थेरेपी ब्रांच सेपरेट. इन सबको अप्लाई करने से पहले हमको फीट को अप्लाई करना पड़ेगा. दैट इज द फर्स्ट चैलेंज. सो एंकल मस्ट बी रिकंस्ट्रक्टेड, लाइंस ऑफ ट्रांसमिशन शुड बी फ्री फ्रॉम restrictions, and the structures made sturdy for job, not weight bearing. Now the point is, our human foot is designed for weight acceptance and transfer. There are two functions, weight acceptance and then transfer. अगर इन दोनों में से कोई भी function affect है, partially or totally, respiratory kinetics will be at heel for sure. So as a therapist, what we do in respiratory world, we reconstruct the foot. It typically takes 4 or 5 sessions, in which we lift all the arches, medial longitudinal arch, lateral longitudinal arch, transverse arch 1, transverse arch 2. 2 is most important for respiratory integration, which is thoracic diaphragm arch. And then comes a separate little lateral arch, which is good for balance and proprioception, which restores center of pressure within the premise of lungs. So we call it center of pressure for the lung. So the mental attitude or the biological concrete are the one which will give a tough fight in physiotherapy, and the patients will be regaining into the movement functions. So functional SCA is the need of the art to be addressed. Whatever kind of function loss is there, we need to reintegrate it through the flesh and blood plasticity, because random body is always deviant and structural integration requires a lot of effort. So in respiratory world, the idea is if we go through diaphragm, we can reconstruct every single soma inside the body. So keynote is carry home messages. We need to format a breathwork session. How a breathwork session looks like? First is we need to balance the pelvis with the lower limb. That's a top priority. Then we need to balance the ribcage with the upper limb. That is the second priority. And then comes the balance to balance the spine. This comes in hierarchy only. We cannot omit or bypass these steps. You don't stabilize the body, you tune it. The idea is If I am moving against gravity, definitely my muscle powers are adequate. If I am going to traditional MMT, it's of no use. Strengthening the muscle which is already strengthened is also of no use. We are just buying hardwares without software. Again, it is of no use. So breathing is a tuner and fascia is a string. That's the carry-on message. So thank you so much for providing me with this opportunity. I was knowing I don't want to go into detail, but hope there are some keynotes that from whatever stream you belong, please incorporate respiratory practices for your patients. There are a number of benefits of it. Biochemical, emotional, physical, non-physical, and all realms of the world. We call it personal, physiological, as well as spiritual realms. Thank you so much. And before closing, as always, I never lose this opportunity to thank my teacher mentors, my God, with whose grace I am here today. Whatever I am here in physiotherapy profession is because of my clinical mentor guide, and my entire life is being shaped because of one person who is Professor C.K. Senthil sir, who was my principal in Karnataka, and he was the one who provided me with an opportunity to be a part of the most distinguished fraternity of this planet, which was Mokashi sir, Dr. M.G. Mokashi sir. So thank you so much. And at the end, the clinical guru and mentor is Dr. K.M. Annamalai sir. Dr. Zafar Khan sir is sitting over here. So Annamalai sir needs no introduction. जो लोगों ने अन्नामलाई सर से उनकी क्लिनिकल टेक्निक्स को एम्बार्क किया है, वो रिसर्च की तरफ बढ़े ही जाएंगे. थैंक यू सो मच.
Thank you so much, sir, for sharing your insights. May I now please request Professor Dr. Supriya Avasthi and Dr. Hema Chaudhary to kindly felicitate Dr. Pallav Bhatnagar. Thank you so much, sir. It gives us an immense pleasure to announce the release of the book Community Health Perspective for Physiotherapy by Dr. Kuldeep and Dr. K. Vijaya. And the sponsors are CBS Publishers PhysioBrid. May I now request Dr. Pallav Bhatnagar, Dr. Vishwajit, Dr. Zafar Khan, Dr. Hema Chaudhary and Dr. Supriya Avasthi to please come forward for the book release. Please give a huge round of applause.
Thank you everyone. Next, we are honored to have Professor Dr. Zafar Khan, an esteemed academician and clinician, currently serving as the Dean and Head of Department of Physiotherapy at Pacific College of Physiotherapy, Pacific Medical University, and an Associate Consultant at Pacific Medical College and Hospital. With a multidisciplinary education background, he holds a PhD in medical microbiology and MSc in the same field and dual master's degree in orthopedic and sports physiotherapy. His professional journey spans over 2 decades, during which he has held leadership roles such as HOD at Siddhivinayak Hospital and technical consultant for various allied health clubs. Dr. Khan is a prolific researcher with an extensive portfolio of over 90 publications in Scopus and MBAS Index journals, specializing in advanced rehabilitation techniques like kinetic chain activation, stroke recovery, and musculoskeletal disorders. Beyond his administrative and clinical duties, he is recognized expert examiner for multiple universities and an active member of the international scientific community, frequently collaborating on workshops involving neuromusculoskeletal techniques and cardiopulmonary rehabilitation. Today, he will be sharing with us the pelvic chair, innovation or comfortability, and objective analysis of urinary incontinence treatment. So may I please request Dr. Zafar Khan to kindly proceed on the dais. Give a huge round of applause for
Thank you for a great introduction. Even I don't know about this. And I'm very thankful to Goenka University to giving me this opportunity. And Dr. Anand, the physiotherapy here, Dr. Nishiji, and Dr. Divya, the younger of us since the UG times. And exactly the topic is I am sharing with you, being a teacher for both the sides, from the medical college side and from the physiotherapy side. I don't believe much in subjective analysis of any studies. I don't believe even in the subjective analysis. I am a bit harsh and not a most favorable person in physiotherapy community because of this, because which I come with the evidences of the radiologically or objectified evidences which the people don't understand and they don't want to engulf very easily. And the history is there, always a female problem which is addressed by a male clinician rather than a female clinician. So I'm not interested at all to develop the stress incontinence studies and any kind of things. But the thing is that the area that Mr. Neil is here, he is basically a company which we have in ALU, which is a US-based FDA approved equipment, and he's forcing me since 3-4 years, so I'm not interested to buy it. I have very expensive toys and tools in my department. But he said, sir, we give it free and just provide it. If I don't get an appropriate answer, I will not publish it. So I go through a data bank which is very interesting. There is 400 plus million cases reporting of urinary incontinence last. And which is nobody is addressing, and everybody is doing up making fool to the patient in the name of urinary incontinence, because which the techniques they are teaching, which is practically impossible rather, or not applicable, or there is no single study of ENG, surface biofeedback or electrical biofeedback which says the Kegel is basically activating the deep muscles of the pelvis or either abdomen, because there is a recording which they are applying which is always either having an interference of the abdominal mortality or rather than basically breathing dissociation, which Dr. Pallo Bhatnagar has already addressed, because the female pelvis, because the reported more in female why incontinence in the male is basically it is always with the post-prostate operation or recurrent UTI or also many very less factors. And the anatomy of a human and male incontinence pathology is the biggest thing is that the female urethra is hardly 4 to 6 centimeters and male urethra is basically 15 to 20 centimeters. So if the dip is there or a drop is there, which people say we feel like we are leaking. So in male it is less important rather than a male because female urethra is very small and it's just if it is a drop and it will then feel that there is something is leaking. And the topic which basically they are saying is a comfortable area because I have a data I will do this. So which I found the anatomical awareness of the physiotherapy, the current physiotherapy is very poor. The older one, they have a very nice detailed understanding of the anatomy, but the physiological application of the anatomy is poor. So in the neurative developmental, what happens exactly? You don't know which is the mouth end or which is the anal end. You never know. Because it started, so our teacher mentor Dr. Goenka Saab says, "Because saas bhi kabhi bahu thi," so you don't know which is saas, which is bahu in the developmental life. Then the neural tube has expanded by the time, and the things develop, and the body develops, and the things which is be changing. So come to the incontinence, because the pearl have to always given to the junior people, because they don't think on that way. Because they found ready to use, they want to do ChatGPT everything. So I always say to my students, you don't get it of parents on the Google, except then you get it everything on Google. So you just, before starting a study, you should have an idea of what you are trying to deal with it. So here basically is an legal chair, and thank you to Neil Padhyay for that, sponsoring such expensive equipment in my department for a study. It's almost a year. And you believe we did only 20 cases, because we don't get it a profound follow-up cases. So for to produce this study, I required minimum 30, but for the spelling, for that expensive equipment for a year, because that is FDA or CE certified equipment is required for the studies. The Chinese equipment, I don't believe at all. And the half of the physiotherapy society are met behind the Chinese equipment, which is a very false informative and don't get a result. It is as good as a toys rather than a tools. Why I am showing this image, I am just describing it because already Dr. Pallav has set a tone for the diaphragmatic breathing and everything, so that all things connected. There is just a very small periinguinal connection, which is everything, which is sling, which is attaching everything, and you don't find it, which muscle is going there and that, and how people irony are saying in the conferences, we can identify liver trani, we can identify coccygeal or external urethral sphincter or external anal. It is not practically possible, especially in the female, because they are both openings which is divided by the pouch of a Douglas, which is very fat pouch, is very false. Even the surgery people do a mistake and females started their incontinence. So you don't have an idea. They are already going with a very wrong hand and very poor techniques, which is no evidences. So the understanding of the technology, which is I am saying, because the people now running behind the pulse electromagnetic waves or SIS superinduction therapy or the new paper which is the people got a novel after the circadian rhythm or cell frequencies. So in physiotherapy, our teacher says normally muscle understand only one language, contraction, relaxation by any means. There is no third language muscle will understand. If you don't understand Hindi or English, and if I am talking in Japanese, there is no use. So if you want to talk the tissue, you have to go on that purview of the tissue. Either then you have to go to frequency-based electromodality, or rather than you have to correct it by the psychosomatic, which is Sir says, or the psychosomatic musculoskeletal induced rehabilitation. So you have only two ways, but you don't have an identified. It is very tough to teach and breathing exercises. How foolish the society of entire stress incontinence practice, which is saying this is not possible. They are saying आप बाथरूम करिए और बीच बाथरूम में रोकने की कोशिश करें. अरे that is a very problem. How fool solution you are telling to the society? That is not a solution at all. Patient is not able to hold the urine. That is a problem. If it is holding the urine in the mid of menstruation, then why he would come to you people? And especially in female candidate, I said if it is a grade 2 urinary incontinence, no female can perform this exercise. No one. I challenge to whomsoever they want to come with the evidences. I have the radiological evidences also, and I have a so-called a false pad test, which is the new NCR society, which is teaching for the urinary incontinence thesis work. Tell me, the temperature variation in the NCR is how much? So if you're doing a study in this season, you will get a delayed result. If you're doing a study in the hot summers, you will get different results. If you do in a rainy season, then you will get a different results. So how are you concluding your study? I don't know. Without of any subjective analysis. So that is basically simple HFM technology, which is basically high intensity electromagnetic pulse, which varies 10 hertz to the 100 hertz, which is less than 15 hertz. We everyone know it's a low current, and then 50 to 150. So which is 150 is again very weak. And why this chair, basically I am saying, I am not a good promoter of the equipments, but for the students, for the college, you require everything on your assets. So see, the electromagnetic pulse which is you are setting on it, and that the perianal region, where you entire perianal region, it will be contracted by him to generating sub to supramedullary contraction. So first thing, second thing is a convincing why it is a very non-invasive, because anything invasive which is a problematic, especially in a female candidate, and it is effective and efficient because it is equivalent to the Kegel co-contraction, which basically the people are quoting. It will do a sub to supra means it will do the lowest contraction, which is Dr. Pallovatna has already told. Little is more effective, more is less effective. It is in our practice, and it is a proven practice everywhere. So there is a specification, because people have very different specifications. So the FDA approved specification is basically 1 to 100 hertz. So why I am again and again forcing is less than 10 hertz, less than 10 hertz. So that is a bloody biological cell rhythm. So if you put an incontinence patient initially for the rehabilitation with control less than 10 hertz, you will get a maximum opportunity to correct and aware the perianal region, rather than you put it direct in an electrotherapy which is required more than 100 hertz of currents. So try to understand the pathophysiology and the mechanics of that chair. Why I am saying this. And how chair works. So already basically that says muscle hypertrophy, neuromuscular education, and anti-aging amnesia. So he is the better person than me, because he introduced me about the SMA. I know about the broad thing, but when I entered with him the Hannah-Thomas theory in 2015-16, then after I am also deep diving in it. So there is a sensory motor amnesia, means your motor control will basically pause or lock that particular tissue which is not a appropriate contractile tissue. Because physiology of muscle is contraction, relaxation. If muscle fails, it is either in short lock or either in long lock. So it is like an on motor. It is basically consuming an electricity but not throwing any water, and it is just same like a muscle. It is co-contracted pattern, and it is generating lactate and biochemical waste, and it will not washing out properly because it is not having a contractile figure also. So always that. So what happens? I am saying you initiate contraction relaxation by any means. So this helps in initiating the contraction relaxation with low frequency. And there is an indications. So why I am saying after 30 years of females, there is a nowadays in Indian case spatial medicine societies, we are not late marriage people, we are not sedentary people, we do whatever means by do the exercises. Now we have a sedentary lifestyle, and in a female there is a one more thing interesting. It is called female pelvic insert. So every insertion or basically a delivery of a baby to a normal vaginal delivery is basically going to sooner or later mark some of trauma or insult, which is basically reported into the higher center, and which is a cascading effect in the incontinence. So stress urinary incontinence is basically a major reason. And second thing is that the pharmacology conference, there are so many pharmacology people are there. Nowadays we are circulating pregabalin, gabapentin, duloxetine like a chocolate to the patient with neurological pain, which is again secondary promoting along with the blood pressure medicine, which is named thiophytochloride. So there is a major problem, stress induced hypertension or multiple pelvic insults nowadays, because society is like this, or either birth deliveries, that all people are doing a cascading effect, and which is basically micro governs macro, macro never governs micro. So that all micro factors basically making the things and macro, and definitely the people who train in the specialty, it is a puzzle, and bits and pieces information available. You have to put the every bits and pieces all together to solve the puzzle. If you go medicine people, they will give a medicine because they trained in it. You go to simple physical therapy, they will teach you the simple physical therapy exercise. If you do some of so-called chiropractic, then he will have a 4 degree of, they have a different 4 degree of organism in their mind. I don't know how that it works. So they are the most foolish people to treat such kind of things. So stress incontinence nowadays is the biggest issue because everybody is in hurry. Even they are not emptying the bladder. It is proven in our studies. The young females not emptying. Second is basically urge urinary incontinence. This is again a false type of incontinence that is basically a psychosomatic, because if you train through the breathing technique or through a proper relaxation exercises, it will correct very easily. Very easy. If patient is not having not any psychosomatic drugs. Then is a mixed incontinence. Sometimes it is a different. Definitely, it is a very problematic for the male and female, both of them, because those who trade in the society which we are living, which is called upper middle class or middle class, we always require good bathrooms. We can't go do for everywhere. So that is again a problem. That is secondary increase in a mixed incontinence. Then chronic pelvic pain, which is again giving a false sensation of a urinary incontinence. Then postpartum pelvic floor weakness, because India में ये है कि गोंद खिला दो, बादाम खिला दो, काजू खिला दो. Nobody is talking about the post-natal exercises. Nobody. Still in the society where we are basically incorporating every modern things in our life. AC भी चाहिए, पंखा भी वैसा वाला चाहिए, air purifier भी चाहिए, but still we are on that norm. The females, those who are in the past times delivering a baby, they have to take care of the food, so that's why they require a high calorie food. So they are doing all this. They have to return to their work as soon as early as now. The Indian government is giving a 6-month maternity leave now in India. Why people are not promoting the society? This is a part of the females. Because you are going to be a daughter-in-law or mother-in-law or daughter somebody. So you people have to percolate in the society rather than other as a male. Then the sexual dysfunction is again mimicking in male and female both, because recurrent UTIs with the multiple partners is again an issue with the stress incontinence. So this is already Pallasar has told, but now I am just putting a light. A muscular somatic pelvic pain due to a pelvic floor muscle overactive or weakness. Why I am using a word is weakness? Because it is either hypertonic or hypotonic, because it governs by the both ways. It is voluntary and involuntary control. So that's why it is hyper or hypo both. In musculoskeletal words, we either say eccentrically loaded or concentrically loaded, but here I smartly use the word physical terminology hyper and hypo, because it is voluntary and involuntary both. And the pain characterized everyone having dull, aching, heaviness, types, and sometimes worse and long standing. And common conditions which I already told you. Where the chair is having a limitation role, where the physiotherapy comes. So I said you, always you believe your basics, because you have understood your basics. Because if suppose patient having a metallic implant, pregnancy or active infection or malignancy, you can't sit on the chair or any electrotherapy you use with the patient. Then you have to go in your basics. So if you have your basic funda clear, then you can apply the equipment well and post rehabilitation also. So here is protocol. I don't want to go the protocol one. Basically we induce for the initial people, because we don't want to create a havoc. We don't want to do a over-education. We don't want to create a tiredness around the perineal region, because there is a very weak muscle. And if the patient having an obese, having a large nucleus, especially female or pear shape, so they are basically locked in the set. All fat comes to the fold. And it will not allow to the sacral rhythm also, and sacral influx of the neuron to the controlling a tool. So you always initiating with the protocol 1. Then gradually you can increase with the protocol 2, where it is a very tremendous and very wonderful protocol which I found. I am not putting in other equipment which I have used Arion chair, so I will be quoting it. I have a data also. I am going to be show you in a minute. So there is a evolution of pelvic floor therapies, that is Kegel, not Kegel, then biofeedback. So I am still not convinced with the biofeedback. If anyone, then he can come in my department. I have a biofeedback also. I have an EMG also. I can go through sonography guided on that muscle, and you teach me that exercise, you will not able to do it. I have already tried all this nonsense. So here is the result which we are basically, I want to publish exactly. This article is not yet published, but Vishwajit has requested me to do that. So with the permission of company, I am publishing this also. So we just registered 20 cases because we required a long follow-up with the every week follow-up, then every 3-week follow-up, then every 6-week follow-up. So there is a 9 female basically came to us in our study. That is not a good thing, but what we can say, because shame is again an issue in India for the incontinence shaming, and 11 are the males. So there is an improvement overall in basically IQI. I am not again convinced with this subjective, but this is a standard scale which every people is using, where we see a 28.18%. And I take everyone attention, those who practice in incontinence, see how subjective is basically worse. And see, so this is a radiological evidence base. We did a sonography in the sequencing, a pre-vital capacity and post-vital capacity, and see the improvement is 56%. Why it is? Everyone can ask the question. Because in young patients, especially young females, don't address their issues, or while they are basically answering to you, they will try to hide the things. And the same patient, when you're doing in sonography, where the pre-vital capacity is showing this, and after sequencing, the post-vital capacity is basically this. So the bladder training basically recorded in the USG-based evidences, because you can get it the pre and post everything. So that's why I am not happy with the subjective analysis in physiotherapy kind of topic like stress incontinence. So this is a scale where we have to show the things. And this is basically a figure which is basically saying that exercises you do this and that will help, which is not like that, because if the organ started to descending, which is we call pelvic floor prolapse, again there is a lack of intra-abdominal pressure, which we already talked about it. I don't want to go into it. So in Ayurveda, we say basically kumbhak. So kumbhak will not help in the later stages. You require in such equipment. It is a wonderful equipment, it is a wonderful tool. I think you incorporate it. But the thing is that you have to understand your basics, because I'm applying all these things before this. And Arion is basically, I have 2-3 equipments, and I am with the research profile now. So I am doing a study, they people are that open, they say, sir, aap istemal kar lo, fir le lena. So you require that boldness, because if you have belief on your things which you are saying, it is delivering to you. The 90% of equipment, especially in NCR, which are sold in the name of lasers, in the name of equipment which are not calibrated yet. And I am telling you, the only physiotherapy community that the laser company is making of fools. A single diode never produced 4 wavelength. Bhai, go into the skin beauty people and ask them. Go to any physicist. It will not modulate it. That is the only company in India is available which is giving 4 wavelength laser with 4 diodes. You can open a machine and check. I want to take a name of any company, and the chair again, they have given you a current, but they will not give you a pulse electromagnetic effect. I am not a promoter here, but the thing is that the equipment is with me since last year. I can present 100 of data I am having, which is 2 or 3 seconds, so I am not considering it as a promising data. This data is allowed me for more than 10.5 months. And with every sonography evidences I have in the portal with the patient alone. So here is my take. If anyone has any question, I am open for it. And thank you for your patience learning, and Goenka University again to giving a platform to share this, and anyone to be a partner in this study. Thank you.
Thank you so much, sir, for the informative and insightful presentation. I will request the session chairs to kindly felicitate Dr. Zafar Khan.
Good afternoon, everyone. I am Goenka, head of department, and the entire faculty of the Goenka University for giving us this stage and pedestal
we were witness to very legends of physiotherapy who were giving talks and very informative session. First, I would like to thank Palla for talking about breath work and resonating with our ancient Indian knowledge system of prana. And I think giving a scientific evidence to our Indian knowledge system is very important. We cannot run issues of another just a piece of literature. And I think you have very well justified it. And I think the students will be using this technique of breath work in their clinical practice. The idea is to integrate the information, the scientific information which has been given here and shared in your clinical practice. After all, the gratitude that we seek is the gratitude of our patients. So that is the ultimate result when we talk about that what is our result-oriented teaching. And I think you all understood how important is breath. And thank you, Dr. Palla, for giving such an insightful talk on that. I think I'm sharing the dice with
Very good evening to all. Just continuing on the note where Madam concluded. It was great hearing both the speakers. Although I'm not from physiotherapy background, but I could gather the information very well, and I believe physiotherapy is going to be very popular in coming times, because we believe that we're going back to roots and we're connecting to our Indian knowledge system, wherein our Ayurveda system has spoken about all this ages back. And of course, talking on what Dr. Zafar shared, I can correlate what he was trying to speak out, and I congratulate him for his boldness and realistic view on whatever he has discussed. And I'm sure once the council gets activated across the country, as we are expecting in next session, National Council, I'm sure all these challenges will be taken care of, because without regulatory body, any medical device is not regulated. So that is one submission from my end, and I congratulate both the speakers and thank you for knowledge sharing. Thank you.
Just a last minute to take everybody to attendance, which is technically one of our doctor, teacher, mentor, because this stage, because what we are sharing both of us because of them. So it's a very easy technique if you don't buy anything. If you are a sufferer of incontinence, there is some take incontinence exercise. You can stand. I will tell you, teach you once why I am saying this sentence to be. You can just realize how we are teaching a wrong technique to the people. So stand and just I will tell you, it is a IPR technique of Dr. K. Analysis. So stand, I will tell you how the things are connected. Please, everyone can stand for a minute. Those who are comfortable, please. So do a one thing. It's a big, आप just statement के लिए जो पलो सर्कस की बात को prove कर देता हूँ. It is the most simplest technique. You people, you just put your hand to your gluteal, lower gluteal, just gently, and nothing you do, just forcefully. So started contraction, so which is why I am saying this. It is an embryological connection. You never know in the embryological development. I am the person who is talking throughout everywhere is the embryological connection of the movement. That is my original work in my research area. So that is a simple thing. If you don't teach anything, please don't teach it the ulti सीधी exercises which is saying बाथरूम नहीं आ रहा नहीं रुकता है ठीक है यूरिन करते समय रोकने की कोशिश करो. अरे बेवकूफ लोगों की समस्या सॉल्व रुक रहा होता तो तुम्हारे पास क्यों आता मरीज. इससे नॉर्मल नहीं रुक रहा है तुम कह रहे हो मिड स्ट्रीम में रोको. जैसे मैं कहता हूँ ना कि मसल रिलैक्सेंट की कोई मैडम अंडरस्टैंड करेगी पिन टिश्यू पंच स्टडी लाके दिखाऊं मुझे पूरी दुनिया में कि तुमने थायरोइड एक्सरसाइज की 4 मिलीग्राम की 2 मिलीग्राम में पे प्रैक्टिस फाइनल मिल गई. मैं प्रैक्टिस करना छोड़ दूंगा. सेम वैसे ही कह रहा हूँ कि एक स्टडी लाके दिखाओ जो कीगल में ये कहती हो. इसलिए मैंने इस चेयर को सपोर्ट किया बिकॉज आई गो टू इट. नील भाई मेरे पीछे पढ़ के मर गए. साहब ले लो सर प्लीज ये कर लो बिकॉज आई एम डेवलपिंग द रेडियोलॉजिकल एविडेंसेस फॉर फिजिकल मूवमेंट साइंस. मेरे को विश्वास ही नहीं है. I put that equipment in my department and I use it. So rather better doing in wrong information. If you have money, buy good equipment. If you don't have, I teach you very simple technique, which is basically a gifted by another to the society. So thank you for pushing.
kindly felicitate the Dr. Zafar Khan. Next, I would like our respected Dean Sir to kindly felicitate our session chairs for their valuable presence. Give a round of applause, everyone. Next I would invite again, thank you Dr. Hema. Again I would request our Dean Sir to kindly felicitate our Dr. Supriya Awasthi with the Academic Leadership Award for her experienced role in the academics since so long. Give a round of applause. Thank you, sir. Thank you, ma'am. For the next sessions or the expert talks, I would request Dr. Mohit Mangla and Dr. Sheetal Malhan to kindly be here for this as a session chair. I would also request Dr. Chandramohan, Dr. Sunil and Dr. Mohit to be here as in the session on the dais. Please come forward.
अरे हम लिए फोटो लिया वो बात में बताएं पीडीएफ में वो नहीं लिखा हुआ है सोने वाला
Moving forward, we are pleased to welcome Professor Dr. Ko Purion, Lecturer, School of Pharmacy, Monash University, Malaysia. Dr. Ko is a lecturer in pharmaceutical chemistry at the School of Pharmacy, Monash University, Malaysia. His research centers on natural product-based drug discovery for neurodegenerative diseases, with a particular emphasis on neuroinflammation and amyloid beta-associated pathology. He investigates bioactive small molecules that modulate inflammatory signaling and amyloid beta toxicity, integrating natural product isolation, relational semi-synthesis and mechanistic studies to identify disease-modifying therapeutic needs. Professor Yong will present an expert talk titled Bridging Natural Products and Neurodegeneration Research, Insights from Mangosteens and Thorns. We invite Professor Yong to kindly take the stage.
Okay. A very good morning to everyone. So it's my great pleasure to be invited to this conference. So it's my first time to India. And then, yeah, it's a very good possibility and very good possibility from Dr. Saki Arora and the team. So I was very treated very well. Okay. So for today, I will present part of my works in Monash, Malaysia, which is bridging natural products and neurodegenerations. Okay, so as you know that as we getting aging, and then a lot of people will be diagnosed or will be diagnosed with some neurodegenerative disease. And as we know that AD is incurable and characterized by progressive memory loss and neuronal cell death. Okay? So it's driven by multiple pathological events such as cholinergic dysfunctions, amyloid beta integrations, and hyperphosphorylation of tau proteins, and so on. So my work for mangosteen, we are focusing on the cholinergic dysfunction and the beta amyloid regulations. Okay? So as we know that many current drugs that targets only one of these pathways, which is partly explain their modest clinical benefits such as cholinergic drugs. Okay? So this raises questions such as, are we approaching a complex disease with an overly simplified strategy? Okay? So why consider natural products? So natural products actually offer a structurally diverse and biologically active drug molecules. They serve as an inspiration for direct source of numerous or clinically approved drugs. So for my works, I'm working on the mangosteen, and the mangosteen has a very unique xanthone structure, which I will explain later. So as a source of hypothesis, they can be tested using modern pharmacological and chemical tools. So xanthone can be found in different kinds of natural products such as plant fungi, lichens, and bacteria. Simple xanthones such as xanthone glyphosate, phenylated xanthones, and oxygenated xanthones. And my work is mainly focusing on phenylated xanthones, and it also consists of diverse pharmacological activity. If you are working on mangosteen, you know that it has anti-cancer, anti-inflammation, and so on. A lot of biological activities. Okay, so why I choose this plant? Actually, this plant is continuous for my master degrees, and then I started my master degree using mangosteen. Okay, so I'm working on the symptomatic treatment of mangosteen such as cholinergic enzymes. So, okay, I will move on later with my work on mangosteens. Actually, mangosteen is mainly oxygenated and phenylated xanthones, and there are about 6 clinical studies that have been carried out to investigate the health potential of mangosteen extracts. However, there is no clinical study on the neurodegeneration until today. So the MDDR concept is multi-target directed agents concept, as we are unable to find the therapeutic for the Alzheimer's disease. We are hoping that by integrating several targets like cholinesterase, amyloid beta, and so on, to help to decrease the progression of the Alzheimer's disease. So here comes the questions. Could xanthones for mangosteen fruit now serve as a multi-target directed agents for Alzheimer's disease? So as we know that if you are working on cholinesterase inhibitor, you can know that there are a lot of the currently available cholinesterase drugs are available from plants such as physoxamine, galantamine, and chelidomids. Okay, so there are several nutraceutical products for cognitive impairments such as huperzines, ibuprofen, and polygonal minus. This is for Malaysia. So first of all, my work is we try to screen for the mangosteen. So we are gathering all the parts of the plants, and then we are doing the extractions. So for this one, we are focusing on two types of extractions. One is methanol extract, and another one is aqueous extract to see the distinct polarity and the compounds of the plants. Okay. So for this study, you can see that. So for this study, you can see that actually for the activity for the cholinesterase enzyme for the different parts of the plants, you can see that actually the chloride contains very certain activity value is 0.9 microgram per minute, and then followed by the bugs and stem and so on. Okay, so for the another enzyme, it's also exhibit. It's also exhibit very potent activity value is 1.94 microgram per minute. So you can see that for the aqueous extract, actually it also contains some biological activity, but actually not much. This is 52 microgram per minute and 11 microgram per minute. So a good judgment for the further study using cholinesterase activity and also for the future drug discoveries. So you can see that for the methanol extract and aqueous extract, you can see that actually the alpha mangosteen has the most abundant contents with the about 500 milligram per minute for the fruit house, followed by plateaus and bugs. So the second abundance is the gamma mangosteen, which is in the green colors. It also contains quite significant numbers of the alpha mangosteen contents. So for the aqueous, actually it contains these xanthones. You can see that actually for the alpha mangosteen, actually about 2 to 3 milligram per minute. For the house and for the bug, which also contains almost 2 milligram per minute. And then the most abundant is another xanthone, which is 3-isomangosteen. So actually, if you are buying some mangosteen juice and so on, which claim that they have very good xanthone contents, actually you can know from here that actually there are very little of xanthone content in the aqueous extract. Okay. So we try to correct the correlation between xanthone content and cholinesterase activity, and then contain a very significant correlation between the activity value for the chloride and for the acetylcholinesterase and cholinesterase. So I also compare the activity values with the known plant extracts, as you may know from the name, such as Indigo bipolar, Purposes, serratas, Centilla aceticas, Neospora, Cordifolius, and so on. Actually, you can see that actually mangosteen has a very good and potent activity value, which is 0.9 microgram per minute as compared with others. These are the activity value I got from the literatures. So the key takeaway from this mangosteen extract study is there's one important message here is that what typically considered agricultural waste, the fruit house of the most biologically valuable parts of the plants. Okay? So this finding has implications not only for the drug discovery but also for the sustainable and resource utilization in the future. Okay. So for the next part of our study, so I isolated about 6 to 8 mangosteen compounds, and then these are the 6 compounds which contain the biological activities. And then you can see that from the biological activity, the carcinogen C and the gamma and alpha contain a very similar IC50 value, is ranging from 1.24 to 2.14 micromolar for the aspartate matrix IC50, and it also contains about 1.78 to 5.14 for the gamma and alpha aminoacids. So next, our work is focusing on the searching for the mode of inhibition of the study, and then you can see that those compounds, although they have similar skeleton, but they have possess different mode of inhibition, such as for this gamma megacin is mismode, and then for mismode for the gamma and the angacinonsis, and some of them is a non-competitive inhibitors. Okay. So for the kinetic study, you can see that actually gamma megacin contains the highest Ki values, which is 2.25, and for the aspartate matrix and the 1.45 for the aspartate matrix, which well correlate with the IC50 values of the mangosine just now. So we done the molecular docking study to check the interaction of the gamma megacin with the active site of the enzyme, and then you can see that for the the gamma megacin actually bind with the choline binding sites through the hydrophobic interaction, and for the aspartate matrix, and it's also bind with the acyl focus for the through the hydrogen bondings. Okay. So we have done for the natural product isolations, and we have found that several compounds contain the bioactivity. But the next work we move on to the we move on with the alpha aminoacid. Why alpha aminoacid? Actually, alpha aminoacid contains the quite potent bioactivity, and then it also has major. It also is a major xanthans of the plant, so that you can get a lot of compounds for the for the synthesis work. And then if later on in the future, if you want to develop these compounds analogs as therapeutics, is also easier than the gamma megacin. But one of the problems of this compound is contain the cytotoxicity activities on different cell lines. So this is our result on cytotoxicity of alpha megacin on the SY5Y neuroblastoma cell line. You can see that actually is killing the cell about 50% at 12.5 microgram per minute. And then you can see that actually it's quite toxic. The IC50 is around 10 to 12 microgram per minute. So actually a few studies have reported the cytotoxicity, and it's uncommon that it's quite toxic in various cell lines, and then you can see that actually it's toxic to human leukemia cells, breast cancer cells, and also increase the ability of BRD1 cells. So we have done a small modification on the hydroxyl group, and then you can find that actually after the modified the compounds, actually the cytotoxicity of the cell actually drop significantly. You can see that actually for the alpha megacin, the toxicity is around 11.2 micromolars, and then you can see that for the all the analogs contains very significant difference from the alpha megacin, which is around 71.9 micromolars to 74 micromolars. The IC50 for across 3 different cell lines is also share the similar patterns. And then we also concerned that there's a loss of activity upon the derivation. Actually, after we found that actually the activity doesn't lose a lot as compared to alpha megacin. You can see that alpha megacin, the IC50 is about 2.5 micromolars, and then all the analogs from the IC50 around about 4 to 6.7 micromolars. But for the without penetrase, actually the activity drops significantly. You can see that actually there are about 5-fold to about 20-fold drops in the biological activities. But the biological activity for the stop penetrase is maintained. Okay. So for the next part of the study, we try to investigate the neuroprotective behavior of the denominator xanthans, and then for the first part of our study, we used 4 different xanthans to screen for the toxicities against amyloid beta aggregations, and then using the C. elegans models. Okay, so this is our published work recently, and then okay. So we are using the dot plot study to check for the in vitro dot plot study to check for the anti-aggregation activity of these 4 xanthans, and then we move on to the most potent xanthan for the docking parts and the in vivo study using C. elegans models. So for the dot plot study, you can see that actually across the concentration, those compounds are really disintegrate the amyloid beta oligomers, and then the carcinoid B are the most potent compounds that carry on for the further study. So for the in silico study, you can see that actually the carcinoid B bind with the protein active site of the amyloid beta protein with the different interactions such as hydrogen bondings and hydrophobic interactions. So moving on for the in vivo study, for the anti-pyrolysis study of the C. elegans, we found that at 100 micromolars, actually the compounds survive against the amyloid beta induced toxicities in the C. elegans models. So this study gives us a better understanding about the neuroprotective studies of the glycine B against the amyloid beta induced toxicities. So moving on, we try to investigate the anti-oxidative stress and neuroinflammation of the compounds, the glycine B, against the amyloid beta induced toxicity in the neuronal cells and also on the LPS microglial cells. So, okay, this study was published 2 or 3 months ago, and then we try to find the IC50 value of the cellular toxicity of amyloid beta 42 in the neuroblastoma cell line before we begin with the challenge with amyloid beta with our compounds. So actually you can see that for this cellular toxicity of amyloid beta 42, the IC50 around 12.3 micromolars, and then this concentration was used in several studies later on for the neuroprotective activities. So first of all, actually the glycine D increase the TSOD, the antioxidant enzymes, also increase the NRF2 and the OH1 proteins. So this study significantly showed that the compound contains antioxidant mechanisms against the amyloid beta induced toxicities. So for the hypothesis assay, we use the SY5Y cells as well, using the NSN and the PIs, and then the flow cytometry study showed that actually the NSN on the x-axis and the PI on the y-axis. You can see that the percentage of every apoptosis is indicated in the real world coordinates, and you can see that this is the control, and then this is the amyloid beta, and then our study showed that you can see that amyloid beta when treated with 0.1 to 10 micromolar, actually the apoptosis value is decreased as compared to the amyloid beta. Okay. So moving on, we also check the mitochondrial membrane potentials of our studies, and then can see that actually the amyloid beta is amyloid beta challenge with the compound, and then challenge you can see that significantly increase the mitochondrial membrane potentials of the by the compounds alone. Okay, moving on, we also check the caspase-induced the effect of calcium D against amyloid beta induced caspase activity. And we check on the three different caspase such as caspase 37, caspase 8, and 9, and then you can see that all compound, the compound calcium D actually reduce the activity of the caspase as compared with the treated with the amyloid beta alone. Okay. So moving on, we also study the neuroinflammation parts of this calcium D with the LPS induced toxicity induced inflammation using the microglia UV2 cells. So this is quite small studies, and also the individual study is a small part of our study. Okay, so you can see that actually calcium D protects microglia cells against the pro-inflammation mediators such as the nitric oxides, TNF-alpha, and IL-1 beta. So moving on, we also try to check the calcium Ds using the Western blot analysis on the TREM2 proteins and NFKB and the PIKB alpha. You can see that actually the calcium D actually increase the activity of the TREM2 also, and decrease the activity of NFKBs and PIKB alphas. So our final study, we use the chronic restraint stress mouse models to study the anti-stress activity of the calcium D. So in this chronic restraint stress model, we study on two different factors. One is the behavior and physiological marker, and another is the molecular markers. So overall, you can see that actually the compounds increase the Okay, overall, you can see that the compound reduce the cortisol levels and also reduce the lipid precipitation for inflammation markers and the phenols. So in these studies, we treated the mice for the 28 days, and then you can see that from the first 3 days is the adaptation days with the open field test and the another test on the 4th and the 5th day, and then there's a chronic restraint treatment with placebo or without calcium D, and with the calcium D at 10 mg per ml. So you can see that actually our study showed that the compound treated with the mice treated with the calcium D actually has a lesser change in body weight compared with the one with the chronic stress restraint models. And also you can see that actually from the serum cortisol levels is a significant reduce as compared with the conditioning model and the placebo. So we differentiate out the brains in the two parts. One is the prefrontal cortex, and the one is in the hippocampus. And then you can see that actually the compounds deactivate the IL-1 beta, and also deactivate these NDA models. And then for the hippocampus, actually the compounds statistically significantly reduce the TNF-alpha and IL-1 betas as well as the NDAs. So in conclusions, that actually in conclusion, that actually there are several compounds from the mangosteen produce distinct type of activity, and then there's a question whether we are using the extract is better or using the single compound, because each compound has distinct activities such as gamma mangosteen, which is potent against the cholinesterase activity. However, the carcinoid Bs from the same extract actually has the more anti-amyloid beta aggregation and neuroinflammation activities. So, in conclusion, I would like to thank all my lab members and collaborators for this work, and then our work will be continuous for the others in both study and the mechanistic study. Thank you.
Thank you so much, Professor Yong, for your sharing of such valuable insights with us. I would request Dr. Sahil Arora and our session chairs to kindly felicitate Dr. Yong. Give a huge round of applause, everyone. We now arrive at the keynote address of plenary session 2 by Professor Stephen Kerr, Associate Provost for Academic and International Affairs, Massachusetts College of Pharmacy and Health Sciences, Boston, USA. Dr. Stephen Kerr is a distinguished educator and scientist with over 30 years of leadership in pharmacy and pharmaceutical sciences. A cornerstone of his academic legacy in his long-standing authorship of Drug Design chapter for Foy's Principle of Medicinal Chemistry, a definitive global textbook he has contributed since 2001. Throughout his career, Dr. Kerr has balanced high level of university administration with a rigorous research program spanning enzymology, drug metabolism, and formulation development. His work is driven by a profound commitment to educational excellence and its international collaboration focusing on preparing next-generation pharmacists and pharmaceutical scientists to navigate the complexities of modern drug discovery. Professor Kerr will be sharing with us on proteolysis targeting chimera's, a new paradigm in drug discovery. We welcome you, Professor Kerr, to kindly deliver the keynote address. Give a round of applause.
Good evening, everyone, and I have to thank you for the very generous introduction. First thing, I'd like to thank Dr. Sahil for inviting me for the REACH conference. I know this was the last minute, but I'm truly grateful for the invitation and be able to talk a little bit about PROTACs. Also, I want to thank all of you for giving me your time today. It's not easy for someone to get people's time these days. Everyone is so busy, and so I do appreciate you spending some time with me. What I thought I'd do today is talk about an area in drug discovery where one is going away from enzyme inhibition or protein inhibition to try and basically interact with diseased enzymes or let's say cancer proteins such that one basically degrades them rather than inhibiting them. So that's the idea of what I'm saying, a new paradigm in drug discovery. So we've heard about inhibitors. For example, if you think of a drug like methotrexate, right, interferes with dihydrofolate reductase. The idea is that rather than just interfering with dihydrofolate reductase, is it possible to actually just degrade the entire protein? So that's the idea. Can we get to a point where we can basically destroy the offending protein in a disease state? And that's the new paradigm. So before I get to that part, I thought I'd give you a little bit of history with drug design. Okay, so if you think about back in the days when people started thinking about proteins and protein structure and then getting to substrates and inhibitors, we can go back to the early 1900s or the 1800s, where Emil Fischer started describing the structure of enzymes, which are proteins, and he described it as this so-called rigid model, the lock and key model, where the substrate is basically the key that fits in this lock, which is the protein, and allows that protein to function. And that was a sort of theory that people held for quite a few years until Koshland came about, Daniel Koshland in the 1950s, who said proteins were not these rigid models, they're not like a lock, very rigid, but they're much more flexible, and Koshland came up with the idea that we have these conformational changes in the protein. So when the substrate binds to the protein or to the enzyme, there's a conformational change which allows for even tighter binding, and then the chemical reaction takes place, an enzyme can catalyze product. And then after Daniel Koshland, Charles Monod came about, and he talked about the so-called allosteric type of molecules that interfere with, or that could react and interact with proteins. And so we came to the so-called allosteric inhibitors. So inhibitors that are not substrate binding ligands, but rather work on sites other than the active site of the enzyme. So that was Monod, and then of course in the early 60s and 70s, we had the anti-metabolite theory, where people were designing drugs now based on the actual structure of a substrate, so that it would all bind in the active site of that protein or the enzyme. And for many, many years, we've actually been in that mode of drug design, where we make a molecule that tends to bind to the active site of the protein, and that way interact and interfere with the function of that protein. Since then, we started using some sort of informatics, if you like, QSAR. There was Corbin Hash, who came about with these so-called parameters, where you could make an algorithm, for example, lipophilicity, electronic effects, molar refractivity, so on and so forth, hydrogen bonding capability, and we can put them into basically an equation and try and come up with the best drug that we could design based on all the different parameters. So that was the QSAR type of design. Then of course we came to these molecular libraries where we could make large quantity or large types of different molecules, put them through a drug screen and come out with a product which would then we could optimize to become into a better drug. And since then, we've got these in silico methods where now before you even take a drug into clinical trials, you basically take them through these sort of, you can think about as AI generated databases to try and predict what their pharmacokinetic properties are going to be, what their toxicity profile is going to be, their metabolic profile, and only then, if they go through all of that from an in silico method, you can actually then take it into animal studies, and then of course human studies with those data. And since then, since 2010, this idea of basically degrading the protein has come about. So let's talk a little bit more about that. I'm going to skip this. This is just all the different models of enzyme action. I'll skip this as well, since these are enzyme inhibitions. If you think about competitive inhibition, you have a substrate binding to the enzyme, giving a substrate enzyme complex, and then product. Inhibitor looks like the substrate, it's like the active metabolite. If it binds, you don't get product. So this is where a lot of our drug chemistry is today, where inhibitor looks like a substrate, it's an analog of the substrate, and prevents the enzyme from basically giving the product. Right? Non-competitive, this is very similar to the Monod's theory, where you have a substrate binding site, inhibitor binding site, and so you have tertiary binding. And once you have something like that, the enzyme doesn't convert over to the product. And so again, you can basically interfere with that particular protein of the enzyme. Irreversible, again, in this case, you've got a very reactive molecule, the inhibitor. It makes a permanent bond, let's say, with the protein and destroys the protein. So basically, you kill the protein. The problem with irreversible type of inhibitor is that it's very toxic because it is inherently reactive. You will get a lot of hits on the off target, and so you get toxicity. And so we came up with a suicide mechanism where you actually have a compound that looks like the substrate, but once it undergoes catalysis, it becomes very reactive, and now it basically acts as an irreversible inhibitor and interferes with the protein. One example of this compound is a drug that we have out there called finasteride. It's used for BPH, benign prostate hyperplasia, and actually that compound finasteride makes a bond, a chemical bond with NADP, okay, and basically prevents NADH actually, because it's a steroid reductase, prevents the NADH from continuing to be hydrogen donor for that. So this is what's been going on, and these are different examples. For example, the sulfametoxazole, sulfonamide. That's the classical antimetabolite. It looks like PABA, paraaminobenzoic acid, in the synthesis of dihydrofolic acid. We know bacteria have to synthesize dihydrofolic acid. Sulfametoxazole basically looks like PABA and interferes in that process. Competitive, if you think of the HIV drug, AZT, it has an azido group in thymidine, azidothymidine. Looks like thymidine, since it lacks the hydroxy group, you cannot continue chain polymerization as the virus is extending the DNA. Okay, so, and this again is a very simple, again, an analog. Similarly, we have another drug in HIV called nevirapine. Basically, an allosteric inhibitor binds not to the active site, but to an adjacent site, and interferes with HIV reverse transcriptase. So these are some examples of what's been happening over the last, 125 years. I won't get through this. The other one that we are really interested in also as a drug design are the so-called transition state inhibitors. So if you think about an enzyme that is catalyzing a reaction, keep in mind, in order to catalyze a reaction with a substrate, basically you have charge separation. When you have charge separation, the energy of that molecule goes up, and enzymes then can stabilize those separated charges. And so one can consider that if you design a molecule that looks like the transition state, the enzyme is going to bind very tightly. And so if you make a drug that can look like the transition state, it is going to be a very, very potent inhibitor. And an example I have over here is this drug called cofamycin. If you look at this reaction, adenosine, which is being basically converted to inosine, it goes through an sp2 intermediate, where you get the hydroxy amino group, and then you go on to inosine. If you get this drug called cofamycin, you can see that this carbon is similar to that 6-carbon in the tetrahedral intermediate. And cofamycin is a very, very potent inhibitor of adenosine reactants. Just to give you some examples, the Km for adenosine is 50 micromolar. The Ki for dihydrochloromycin is 2.5 picomolar. So you can see almost a 10 raised to 9-fold difference in binding ability for transition state inhibitors. I should mention today a lot of drug companies are looking at transition state inhibitors. Some of the most let's say, potent drugs that we have, especially for AIDS, are the protease inhibitors, which are all being modeled as a transition state inhibitor. So that's been going on for all these years. And the idea is that can we change that philosophy of just looking at enzyme inhibition? As part of that, the idea is that, okay, well, how many proteins do we actually know that we can inhibit from a clinical point as well as from, let's say, a non-clinical point, and do we know what some of these proteins are? So if you think about the human proteome, all the proteins that we can have in the human body, clinically there's only 3% of the human proteome that we can drug. That are drugs, meaning we've got drugs to treat diseases for only 3% of the proteins. While we know about proteins that there are molecules that can interact with them, but they're not yet been approved as drugs, that is around 6%. So chemically known proteins, because we have molecules that can interact with them, that's 6. Only 9% of the proteins that we know about we can interact. What about all these other proteins? So biologically we know there's many more proteins, so we know what the protein is, but there's no molecule that we can interact with. And then there's something known as the dark proteome. For example, some of the transcription factors, we have no idea what these proteins are. And we call it as the dark proteome because we actually have no knowledge. And so the question becomes, if there are these proteins that, if you think of this, 38 and 53, I mean, that's a huge number of proteins that we really don't have any molecules to work with. And if these are some of the proteins that are causing diseases, how do we treat those diseases? It becomes a really difficult way. And so, how can we change our thinking of finding a drug for proteins that are in this block? The dark proteome, or even though we might know them, but we don't have any sort of chemicals to treat them, right? How do we then treat a disease for that? Well, that's where the idea of PROTACs came from. So what is a PROTAC? So the way a PROTAC works, as you see the word PROTAC, I mean, it's a proteolizing, targeting chimeric. Proteolizing because it is making use of the body's inherent ability to degrade proteins, right? What is the inherent way that we degrade proteins in our cell? It is through the proteasome, right? Any protein that is made in the cell, once it does its function, after its function, it needs to be basically processed. The way it gets processed is that it is basically tagged by a compound called ubiquitin, and it's targeted to the proteasome where it's pretty much broken up into its fragments. And so the idea was, if you think about how the proteasome works, basically there are 3 enzymes. You have the E1, right, which is the activating part of the proteasome. The E2, which is the conjugating, which basically puts the ubiquitin onto the target protein. And then the E3, which is the ligase, which is then going to target the protein of interest so that you put a polyubiquitin and then it sends it to the proteasome and it basically gets destroyed. So you think about the substrate over here, this is our protein of interest. So you can think about this as a disease protein, right? So if we can target the disease protein with this ubiquitin, we can take it and just degrade it. So rather than having an enzyme inhibitor, which we've been talking about for many years, if we can target this through the proteasome, it makes our life a lot easier. And so that's where the idea of PROTACs is. So what we would like to do is be able to get the protein of interest and basically polyubiquitin. That is the concept of a PROTAC. So let's see how we can do it. So this is the same thing, I'm not going to go through this, but I'm going to talk about So proteolysis targeting chimeras, they sometimes are also known as targeted protein degraders. That's another term, TPDs, targeted protein degraders. The way they work is that one part of the molecule basically must bind to the E3 ligase. So the ligase is the one that is actually going to ubiquinate the protein so that it goes into the protein. The other part of the molecule should bind to the protein of interest, so which is our disease protein, right? So the protein that's causing the problem, we want to destroy it, and so we need another part that is binding to that disease protein. And we have a linker between the two, meaning if this is bound to the E3 ligase, this is bound to our offending protein. Because it's bound to the ligase, we can basically polyubiquinate the protein of interest and then send it through the protein. So the way it works, this is our molecule, the protein, and I call it bifunctional because it has two functions. One for the E3 ligase and the other to bind to the offending protein. We combine the E3 ligase part binds to the ligase. Once it binds to that by the linker, this protein now gets targeted to get polyubiquinated, goes to the proteasome, and we can break it up. And keep in mind, the protein is actually recycled. So the protein does not get destroyed. It is only the protein that is destroyed in the proteasome. So that's the idea. So let's see. And this is again what happens. The target is the protein. We bind the target with our protein. We tag it with the ubiquitin, then degrade it with the proteasome. Because the protein is not degraded, it can recycle and bind the target again, right? And so it becomes, if you think about it, it is a catalyst, right? One single molecule of a protein can basically degrade an unlimited amount of protein molecules. So that's the whole idea. Has anyone seen a structure like this before? Do you have any pharmaceutical scientists over here? Okay. This compound is called thalidomide. Anyone heard of thalidomide? Okay. So back in the early 1960s, thalidomide was basically used for women who were early in their pregnancies to treat some of the effects that was associated with pregnancy. And unfortunately, no one knew at that time, but some women, when they gave birth to their children, the children came out with some really massive deformities. Okay, and basically this molecule became known as a teratogen, and no one really knew how this drug actually worked. Why did it cause those teratogenic effects? Well, it was not until basically the 2000s that the true mechanism of thalidomide came to be known. And what was the true mechanism? Okay. It's that thalidomide binds to an E3 ligase. Right? So it is basically a substrate for E3 ligase, but it can also basically allow for certain other proteins to bind to it. And some of the proteins that bind to it are the SAL4 and P63. SAL4 is basically an embryonic stem cell transcription factor. P53, of course, those of you who know about cancers, P53 is a very important protein as far as cell cycle. Right? And so what was happening, thalidomide was basically binding to the ligase, at the same time binding to these transcription factors that were very important in embryonic stem cell development. And taking it through the protein circuit then polyubiquinate these transcription factors and basically destroy the transcription factor. Meaning, the transcription factor then could no longer activate the gene in order to continue the embryonic development, which resulted in the teratogenic effects. And this only came to be known in the 2000s. And so the idea was that, well, if thalidomide can do that, maybe we can make use of a molecule like thalidomide, where rather than binding to an essential transcription factor, bind it to a protein that is causing a disease. And that way we will be able to harness, take that disease protein and degrade it through the protein. So that was the whole concept of making this so-called protein. From that, we started doing a lot of drug development and looking at different molecular entities. And from the original thalidomide type of moiety, we got a whole bunch of ones that based on that thalidomide structure. The manalamide, malidomide, and then there's also CC885. And the idea was that, well, if we take these moieties, put a linker, attach it to another ligand that will target the protein that we want destroyed, we will now be able to harness basically the ligase system to destroy the offending protein. And so that is exactly what they did. So you can see through drug development and drug modeling, they came up with a whole bunch of these types of thalidomide type structures. You can put linkers on it, attach it to something that will bind to the protein we don't want, and that way type of destroy that protein. Keep in mind, thalidomide binds to a particular ligase called cerebron. In the human genome, we have close to 600 different E3 ligases. 600. Cerebron is just one of them. And so there is a lot of potential to try and develop these proteins, because we can potentially work with 600 different ligases to try and basically degrade our proteins. And so if you think about, here's our thalidomide structure, right? So it binds to the ligase, and it also binds to this neosubstrate, which is another word for protein of interest. Okay, a neosubstrate, for example, the protein that we want to try and kill. And so we can get these molecules that bind to the protein of interest and basically degrade them. Neosubstrates, we could think about these as, for example, tumor antigen, one example, or some transcription factors that are involved in cancer, right? Target these neosubstrates. And you can see that just some different types of examples. But here's some data I've taken from a paper where they've taken this drug, palbociclib. Basically, palbociclib is a cell cycle dependent kinase inhibitor. It is used in certain cancers today. Okay, it was a drug that is used in certain cancers. So they took that palbociclib, they put a linker and linked it to this ligase binding domain like thalidomide, right? And they looked at, okay, can palbociclib pick up the CD4 and destroy it? And right now, this is some of the work that is going on in drug development. Another drug that they looked at is this ARV-110 and ARV-471. These drugs over here, this is a ligand for certain estrogen receptors. Okay, again, take a linker and put it onto that thalidomide type of structure, and that way we can destroy basically the estrogen receptors. So those cancers that are, let's say, responsive because of estrogen receptors, for example, breast cancers, we can try and link it with basically something like this. And right now, ARV-471 is actually in clinical trials. In fact, it might have been approved as an NDA. So cerebron, the thalidomide part was basically for one ligase, E3 ligase, the cerebron ligase. There is another ligase that we probably know about, which is the 1-hippo ligase, which is involved in hypoxic inducible factor. And certain kidney cancers, this hypoxic inducible factor is activated. And so the idea is that if we can target the 1-hippo ligase, we can basically might be able to use it for certain cancers. If you look at the structure for the one-hipple ligase, this is the moiety that tends to bind to the VHL ligase system. And so we can put a linker on a substance, on a compound like this, and then target those cancers that might be involved through the facilitation of the one-hipple ligase. Similarly, we can have, again, you can see in this case the one-hipple ligase. This is the tyrosine kinase compound, gefitinib, again used for certain cancers involving tyrosine kinases. So you put the one-hipple ligase substrate, link it to the tyrosine kinase binding domain, and so now we can try and degrade the tyrosine kinase. So again, a potential use with certain cancers. People have gone even more novel ways where they're looking at taking basically the one-hipple ligase domain, linking it to the cerebron ligase domain, over here, and basically destroy just the ligases as well. So you can mix and match, and these are just examples of how people have gone about mixing and matching these different substrate binding domains for the ligase and for different proteins. Here's an example of this that simultaneous degradation of both the ligase and the one-hipple Lindau ligase and the cerebron ligase. You can see, in this case, this is the one-hipple, this is the cerebron, and basically you can destroy both ligases because it basically targets both ligases through the protein. And so, like I said, there's a lot of potential of trying to do this type of work. This is a drug which is basically right now has been approved as a new drug application in the FDA, basically used for estrogen receptive breast cancers. You can see, so this is the part, the binding, let's say this, the ligand for the estrogen receptor. This is the ligand for the cerebron E3 ligase, and so this has actually gone through clinical trials. NDA has new drug application being accepted by FDA in August of 2025. So right now this is already been accepted as a new drug application. We can think about in the future, and right now it's a hot area for pharmaceutical companies. Many pharmaceutical companies are looking at this type of model in order for drug development, where they're using these so-called targeted protein degraders or these proteolizing targeted chimeras, which are basically the same thing in trying to be able to use different types of here's another one for immune diseases, where they've used again a cerebron ligase binding domain with immune modulator, which is 8474. This is the Sanofi been working on it, except that it went to phase 2 and then they stopped it, but they performed a new drug, but they've not yet released the structure. I don't know what that structure is, but it was not called 8485, right? You couldn't find the structure. 85 still right. But again, very similar concept. Finally, I'm going to end with this slide to just show you the difference between the small molecule inhibitor, which was the traditional drug development. You make a small molecule, it interferes with the action or the activity of a protein versus a protein degrader. The major point over here is that in the case of proteolysis targeting chimera, advantages, we can target pretty much any protein as long as we have a moiety that will bind to the protein and then a linker to an E3 ligase binding. That's all we need. Does not need active site binding like a regular active site inhibitor. Does not need high binding capacity. You don't need very potent binding. Does not compete with the natural substrate. And that's what we call the new paradigm. Keep in mind, there's always challenges in any drug discovery. Toxicity, off-target degradation, we saw that with phyllidamide. It might happen with our new products. Pharmacokinetic stability, metabolism, distribution. distribution. Right now, we only know about 2 or 3 ligases that we can use for targeting, but the potential is there's 600 ligases out there, so we could find some more resistance, and then again, finally the prediction of the toxicity. So that's what I wanted to share with you, and just give you a perspective of what is coming in the next maybe 5 or 10 years, and it's something those of us who are in pharmaceuticals development or just in the general healthcare field is to, there's a lot out there, there's a lot we don't know. Maybe a model like this will help us to understand some of the proteins that might be causing some of the diseases. So thank you again so much for your invitation. I hope I've been able to share something about
Thank you, Professor K, for sharing your insight with us. May I now kindly request Dr. Anand Singh to kindly felicitate our speaker, Dr. K. Please give a huge round of applause. Thank you so much. As we come to the conclusion of the plenary session 2, we would like to express our sincere gratitude to all our distinguished speakers for their insightful presentation and valuable contribution to this session. Now, I am handing over the stage to Dr. Sheetal Madhan, Associate Professor, Department of Physiotherapy, to continue with the panel discussion.
Good evening.
So as we are concluding this day, I would like to invite Professor Dr. Anand Singh to please deliver the closing session for the day.
Sorry, I just skipped my steps. Good afternoon, everyone. So today is the first day of International Conference Week, 7th International Conference, and today we have a huge number of students who have traveled from far away to participate in this conference. Most of them from the Dehradun, Jaipur, Udaipur, and our most honored resource persons are sitting here in front of me. So thank you so much for coming here and actively participating in this conference. And still we have lots of good resource persons with us, 4th and 5th technical sessions and program presentations tomorrow also. So looking forward tomorrow also to see you here. And thank you everyone for coming here. And all the resource persons, especially thank you for enlightening our students with your great knowledge. Thank you so much.
Thank you so much, sir. Now I would like to invite all the esteemed dignitaries and guests, all the faculty members for a group photograph.